Thank you all. Thanks, Sam. Thank you all so much for joining us today for this very important conversation about positive behaviour support for people with young onset dementia. So my name is Jade Cartwright. I'm the co-chair of the Australian Young Onset Dementia Special Interest Group, which is a network of over 100 researchers, clinicians, people living with dementia and their families, with a shared goal of improving outcomes for people with young onset dementia. So before we do begin today, I would like to acknowledge the traditional owners of the land upon which we are all meeting today and pay my respect to their elders past and present. And I stand for a future that profoundly respects Aboriginal knowledges, culture and history. So our recent YOD-SIG Joint Solutions research led by Associate Professor Samantha Loy for the Young People in Nursing Homes Alliance highlighted that we need more effective, timely, age-appropriate, personalised and streamlined responses for younger people with dementia experiencing changes in behaviour. And that is the topic of our conversation today. So we have a fantastic lineup of speakers and really do hope that the insights, the principles, the resources shared will provide direction for positive behaviour support and for future service innovation and development. So today's webinar will run for 1 hour. And you can place any questions that you have in the Q&A box at the bottom of the screen as we go. We'll either respond to those questions during today's event, or we will answer them offline and circulate those responses afterwards, just depending on how we go for time. So to start us off today, it is my great pleasure to introduce our first speaker, Catherine Moyle. Catherine is a carer for her partner with frontotemporal dementia and an advocate on the Dementia Australia Research Foundation Scientific Panel. Catherine is also an advocate, member on the steering committee for the Care to Work project at Monash University, funded by the Medical Research Future Fund. So thank you so much, Catherine, for starting off our conversation today.
Thanks, Jade. And to get us started, I thought I'd just give a little bit of background about what happened and how we came to the point we are now, and then to talk a little bit about some of the strategies that we have put in place. So my partner, Chris, he was diagnosed after about 10 years of unusual behaviours. And when I say unusual behaviours, I mean things like he would get lost in places that he used to know. He would get angry and upset about certain things that were never a problem before. And his overall resilience just seemed to disappear. He had a legal background, and I noticed that he was taking a lot more notes about things that he was doing, and he started to record and make video recordings, and then playing those back of social situations. Now, taking video recordings of social situations without permission is actually not an okay thing to do. And he, in his earlier life, would know better than that. So my alarm bells were ringing, but it took me a long time to be able to get him and to convince him that he needed to go to the doctor and to be assessed. After a period of time, he was assessed with frontotemporal dementia. He had a PET scan, and it showed that his brain was over 2 standard deviations away from what was considered normal for his age. And so that was a real indicator that we need to change our life. We were told, because it's frontotemporal dementia, that he had 2 years to go and get your affairs in order, which is kind of code for you don't have much longer to live. And we were devastated that. We decided that we would keep the whole thing secret. We'd just tell a few friends and make out that life was actually normal. Well, this was completely untenable. It wasn't fair to our friends, and we decided it wasn't fair to our friends because we were asking them to keep secrets that really were impossible to keep. And after a period of a few weeks, we decided we'd flip that whole thing around and we decided we'd tell everybody. And we decided to tell everybody and to take on advocacy. So we wanted to be able to contribute to the stories of people's handling dementia. And we wanted to be able to also get involved in any trials that might be going. So Chris put his hand up for participating in several medical trials and being able to contribute to what we understand about dementia today. And so we see a lot of people who struggle with that, that trying to be an advocate or making out that everything is normal when it's not. I spend a long time apologising for my partner's behaviour because he has behaviour variant frontotemporal dementia, which means in several situations he is antisocial, and I would spend a lot of time apologising. We now let people know that he has dementia, and we've found people are very understanding about that. Sometimes people are cruel, but mostly people aren't. Indeed, we caught a taxi yesterday, and my partner has what are called myclonic jerks. They're involuntary jerks. He lets out yelps, and it happens without his control. And the taxi driver was a bit puzzled. So I explained to the taxi driver that this is what's happening. The taxi driver was terrific. He told his own stories, and everything was fine. But the taxi driver was really quite puzzled at first when he was letting out yelps about things that the taxi driver had no control over. So some of the things that we've done, that's a bit of background about how we came to be where we are. But to be able to maintain my sanity, because frontotemporal dementia with the behaviour variant is a challenge, I've learnt to be a lot more patient than I ever used to be. And I had to stop full-time work. I retired early because I just could not handle the stress of my job and the stress of never knowing on what was going to happen on any given day. So we applied for, and well, I put it this way: my partner was assessed, Chris was assessed for a home care package. He has a home care package level 4. That whole process had challenges in and of itself, but the people that were doing the assessments were fabulous. They helped us through all the processes. And now my partner has a carer that he loves to see twice a week. Now, that's really important for a number of reasons, mostly, though, because he gets to go and see someone else other than me. And it also means he gets to do the things he wants to do. He chooses what he wants to do. Not that he doesn't choose with me, but when you're living together, you have to get on with each other, and not every choice is about him. But with his carer, he gets to choose, and he loves that. He goes out for walks, he goes to the movies, he goes and does the shopping with careful monitoring, and he goes to art galleries and so on and so forth. So he loves that. Importantly to me, it's respite. And one of the things I learned is that respite is absolutely fundamental to being able to keep being a carer. It's a bit like when you're on a plane and the thing says if the mask drops and you need to put it on for oxygen, to do that first before you help someone else. I can't stress enough how important it is for the carer to be able to look after our own health. And after COVID, I went on a long holiday, and I was really close to being at the end of my tether. And I had a good break, and I came back and I was able to keep going. And if I hadn't have done that, I don't think that I would have been able to continue to do the caring that I've been able to do. Respite is absolutely fundamental. Around our home, we have a number of cues for being able to help my partner stay as independent as possible, because when we had the home care package approved, our stated goal was we want to keep Chris at home as long as possible. And so one of the conditions my partner suffers from is he can choke when he's eating. So there are a number of things that we have in place, but one of them is that there's a sign on the wall and in several rooms of the house of 000, because if I happen not to be in the house, I am most of the time, but if I happen not to be in the house, then the zero number is up on the wall, because he did experience once when he was choking and he could not remember the 000 number. There's signs up on the wall that say, turn off the kettle after you've boiled water. We have cues around the house, and those cues really help to contribute to him remaining independent. So, as I said, he was diagnosed with dementia, and we were given 2 years. Here we are, 9 years down the track, and he is still alive and kicking and enjoying life. I can see his cognitive decline, and he's actually going through a period of quite rapid cognitive decline at the moment, and I can see that, and that ongoing grieving hasn't gone away, but we make the best of it. So, Jade, thank you for the opportunity to tell you a little bit about us.
Thank you, Catherine. That was, a wonderful kind of reflection, and thank you for sharing your experiences. There's lots of really wonderful take-home messages from that. I really hear that importance of sharing the diagnosis and being open as a way of providing that opportunity for people to provide support. And I think lovely that when you share your story, you hear that many people have stories of their own. But most importantly, it's great to hear the ways you work together to find those creative solutions to adapt and to really optimize your participation together. And also, really important around that need for carer support. So thank you. So kind of following on from Catherine's presentation, I would now like to introduce our second speaker, who is Dr. Alinka Fisher. Alinka is a senior lecturer in disability and community inclusion in the College of Nursing and Health Sciences at Flinders University. Alinka has specialist knowledge and skills in the area of positive behaviour support. So thank you so much, Alinka.
Thank you so much for having me. I just wanted to say thank you to Catherine. What a wonderful start to today's presentation, and I feel incredibly privileged to be here, and so privileged, I guess, to have shared the story of many families and people that we've worked with throughout our research. I'd also just like to acknowledge very quickly, I know we don't have much time, that I am also joining here from unceded Kaurna lands in Adelaide, and pay my respects to elders past and present, and also would like to acknowledge that those intersectional experiences of First Nations people living with early onset dementia as well, and their families and caregivers. You're going to probably see very quickly that I could be talking about this topic all day, but my purpose really here is to give you a very high level introduction, and hopefully start, I don't know, maybe fueling some curiosity in you to learn a little bit more. So positive behaviour support, it's really I'd like to frame it as a practice approach rather than a specific framework or model. And the reason for that is that there's lots of different PBS frameworks and models. So I'm going to talk a little bit now just about some of the key principles of positive behaviour support, and as part of this, really sort of thinking about this obviously in the context of supporting people with early onset dementia, and also families and carers, which has been a big body of work that we've been involved with. So let's first just start with thinking about PBS as an approach to providing behaviour support. PBS, I just want to be really clear, is not a diagnostic-driven approach to behaviour support. It's process-driven. And what I mean by that is it provides us with an approach really to work with anyone, any person with very unique backgrounds, diagnoses, experiences, circumstances, and across settings. And that's what I love about it so much. I've used PBS in so many different settings with so many unique people with wonderful benefits. It's also integrates and learns from a whole lot of different fields and principles. We're constantly learning, and PBS as an approach is definitely evolving and with some growing evidence. And it's been wonderful to be involved in the work through the Brain and Mind Centre with Professor Olivia Piguet. Sorry, I wanted to also just say a shout out to Claire O'Connor, Candy Chung as well, some great colleagues of mine, and involved in some of the early and only pilots actually in PBS for those living with younger onset dementia. So PBS integrates behaviour analysis, prevention and implementation science, and what that means is we're understanding more about the evidence that underpins the work that we do and the knowledge that we need to have to make sure that we're not just focused on, for example, developing some great strategies, but actually how they need to be implemented and how we need to work as a team and very much value and prioritise those lived experiences and living experiences of people that we are working with. It's very much about not I've got to stop talking because it's the first slide, right? I'm going to keep going. Talk to me later. We've done a lot of work in thinking about PBS as a process-based approach, and I'm going to refer to some recent work we've published with a few QR codes and some references. So if you are interested, you can follow up in your own time. But it's really important to note that PBS is aligned with a rights-based and by approach and utilises the biopsychosocial model. This is really important context when working with people, with all people that bring very unique experiences. But in the work that we've done with families, it's actually sometimes a little bit of an aha moment when we unpack this and talk about the dementia being a very important factor to consider. Thinking about the changes at the neurological level, which will sometimes we see common changes, but obviously everyone's experience of the disease and the disease progression is very, very different as well. So understanding what those neurological factors that influence those cognitive and behavioural changes, but also there's so many other factors for us to be considering other predisposing factors when we look at a person's culture, when we look at environment, when we look at moving from settings, from living at home to perhaps transitioning into a residential aged care environment, the people in our environment, the relationships we have with those people. There's actually so much that we are in control of to improve those environments and learn from the people within those environments, and obviously with that person themselves being the primary stakeholder. So there's just so much that we can do together, and it's a really empowering conversation to have with families. And yeah, again, I've linked to some of our research, but I've just wanted to say I've had the absolute privilege of working with I think about 70 families, which is wonderful, and a recent project that we finished where we did, and this group was 50 family members, not all of them though had younger onset dementia. We were quite inclusive in that particular research project, but we did have that published and had some really amazing outcomes. So yeah, I'll refer you to that. So I just wanted to also say that I think when people think PBS, they think NDIS. I don't know if I'm putting words into your mouth. That's perhaps in Australia, NDIS is one of the primary funders of PBS because of the way that it's explicitly funded and articulated. But actually, PBS has been around for a long time, and there's lots of different frameworks and approaches. It's been, I think, as as people interested in PBS and wanting to know more about it, it's also important that we look beyond the field of dementia to other areas where we can learn and consider and apply principles into the work that we do. So we need to think about PBS as a service response. Often when we think about PBS, we think about targeted, individualised, comprehensive planning, but actually there's so much a part of providing behaviour support that sits at a service level, at a family level, at a community level. When we think about learning about a person, making sure that that environment is appropriate for that person, that we're supporting their access, we're supporting their involvement and participation in a way that's meaningful, that's culturally appropriate, and all of those things. So this is a paper that we developed. You may be interested or not, but it presents PBS as sort of a tiered systems-wide framework for disability, but also community service settings. It's not specific to disability, but again, presents PBS as a process-driven approach. And I did lots of work with this in our residential aged care pilot, actually, and huge amounts of interest around sort of establishing those more foundational features of PBS. So we've got these guiding principles. I'm not going to be able to go into heaps of detail about each of the guiding principles given time, but I just wanted to, I guess, emphasise that PBS is aligned with a rights-based approach. And what we mean by that is we're not coming in with, when I say we, as anyone providing positive behaviour support, we're not coming in through a lens of what can we do here to change this person, to make them behave in a way that is acceptable or appropriate to others, but we have a big focus on understanding them as a person, as a citizen, as someone that brings really unique strengths and backgrounds, and absolutely they have dementia and there might be some challenges associated with some of the behaviours that we're experiencing, but there's also challenges, by the way, associated with the behaviours of others within and across support teams as well. So just wanted to really emphasise the fact that PBS is really about placing that person's voice and their family at the forefront and understanding and addressing all the underlying reasons for those behaviours that might be presenting a challenge. I would love to have a big conversation with you all about language. It's such a passion point of mine, and I work with families that, go, oh, what language are we meant to be using? And I'm like, well, whatever language we're really comfortable with. We just need to be really clear that when we're talking about behaviours of concern, or I know that there's specific guidelines and language, we need to be always mindful of those things. But really the most important thing is that the people that we are working with understand process and are comfortable in the way that we are talking about them, we're talking about their behaviour, we're talking about our strategies and our approaches to help support them in the best possible ways. We're also looking at prioritising the systems around a person, and definitely always thinking about evidence-based and informed practices. I want us to think a little bit loosely about, not when loosely, that's a very bad term to use here, but when we think about evidence, right, we're not just going back to the scientific literature and going, oh, where's the evidence for that and that? And there's some evidence that exists for reducing behaviours, but actually PBS isn't about a focus on reducing behaviours, it's about improving quality of life. And so there's a lot of literature that we need to be thinking very critically about with a very contemporary and rights-based lens in the way that we think about evidence. But also here, I really just wanted to make the point that evidence is information. And so when we're working with a person, when we're working with families, we are learning from them what is important, and that's evidence. So our evidence-informed practices are about taking that primary evidence that we're learning about a person, about their environment, about their situation, about their specific dementia, what that dementia means for them in their unique situation and the progression of the disease, and how that is going to inform our planning. Now, you're just going to have to jump in, and Jade, and just put your hand up maybe when I've got 2 minutes left. Is that all right? Because I know I'm getting close, or have I already gone out of time?
You are close. If you've got a couple of minutes to wrap up, that's great.
All right. So a little bit of a trigger warning because my next slide is a bit busy, but I just want to put it up there and talk 1 minute to the slide, and then hopefully that sparks some conversation going forward. This is a busy slide, so if it's too busy, just focus on me talking, and don't worry too much about this. See it as a prompt for me. But what I just really wanted to say, that one of the probably the most exciting outcomes that we've had working with families is an understanding of PBS process. In fact, it's been one of the things that's been reported as the most valuable in understanding what you might have heard, and if you haven't, referred to as function-based planning. And really what this is about is understanding all the things that influence a person's behaviour, the things that actually are creating challenges for them in the environment, things creating challenges for others. And our specific behaviour and individualised behaviour support plans should all be about addressing the things underlying the reasons that that behaviour is occurring. That's what we mean by a function-based intervention or support plan, right? And that's really important, because often what I'm hearing the families say is that there's all these strategies that people are telling us to try, and they're all really, sometimes they're good, sometimes they're not working for us, they're not, you know, we're not feeling like they're necessarily unique or targeted or tailored to our individual situation. And so to have a really particular focus, and we talk about target behaviour again, just as this is a particular thing that is presenting a challenge right now that we want to understand, right? Once we understand the purpose, the reason, the influencing factors, then we can map those directly to support strategies. And we have so much success. In fact, yeah, I mean, I would argue that I've never seen PBS, when it's done properly, not make a positive difference and help support others. So anyway, we have the PBS pathway framework is published. You can have a look. I don't know if we were circulating slides, but I've created a list of a few other references that I thought might be helpful. As you can see, there's so much that we could unpack. It's such an incredible field to be a part of, and yeah, might get the opportunity to go into a little bit more detail at another time. So I'll stop there and answer any questions later if there are any.
Fantastic. Thank you so much, Alinka. We'll absolutely circulate your slides and those great resources that you've shared. I think you've absolutely fueled curiosity, which is great. And I really appreciate you kind of really emphasising the need for us to work as a team, to work across levels, but most importantly, to keep the person and their family at the centre of everything we're doing. So thank you for giving us that kind of high-level overview, incredibly helpful. So to extend that further, I would now like to introduce our next speaker, who is Lorraine, an occupational therapist working in the Mental Health Division in the Southern Adelaide Local Health Network and a PhD candidate at Flinders University. So thank you so much, Lorraine. We're just still on mute, Lorraine.
There's always one more thing. Thank you so much for having me. Given how little time we have, I just want to say thank you to everybody, and just to quickly acknowledge the traditional custodians of our land, and also people who have lived experience of dementia, those who care for them and those who care about them. This is positive behaviour support, such a inspiring and exciting area to be working and researching in, and my involvement has been predominantly through clinical spaces, so through older persons' mental health, and also in the neurobehavioural units that are popping up. And I work as occupational therapist. I'm going to briefly just discuss the OT role, which is not always common, evidence-based interventions, and make some suggestions for intervention use and research. So firstly, occupational therapist.
Sorry to interrupt you. Did you want to share your slides, or were you happy to just talk?
Are they not? Sorry, they haven't come up. Oh,
no, they haven't.
Try that again.
Thank you.
I always have something happen with my IT. It's a special gift. There we go. Is that working now?
No, I can't see them yet. Oh, yeah, here they are. They're coming.
There we go. Okay, lovely. So, OT is a client-centered profession, so its goal is to help people participate in the activities of everyday life, and so that might be showering, bushwalking, or anything. When a person's behaviour interferes with them being able to participate in the things that they want, need, or are expected to do, then like any other sort of activity difficulty or functional difficulty, occupational therapists can help understanding what's causing or contributing to the behaviour, and what interventions might help to minimise the impact of that behavioural response that they're experiencing on the person's occupations. And this little word cloud is kind of an indication of a few of the things that OTs think about when they're thinking in this space. You'll find OTs working in a range of different areas where they'd apply these skills, and this slide is just a few examples of what OTs might be involved in when they're supporting people. And because the OT's work is not always well understood in a lot of areas, not just in positive behaviour support, I just thought I'd go through a quick case study. So this is an example of a previous client of mine. This gentleman lived at home and his showers would take over an hour. He'd get incredibly frustrated, and if his wife attempted to assist, then he'd become upset and he'd often try and get her to leave so that he could get on with it. Now, the three of us got together and we identified what the main challenges were, which were his desire for independence, the loss of cognitive skills to manage the tasks, and the huge power and water bills that were starting to accrue. Together, we analysed the challenges and we ended up making the following changes. So we modified the physical and the social environment. We did things like installing markers to indicate how far he should turn the taps, and developed prompts for his wife that he didn't find frustrating. We modified the activity by changing its meaning so that it became about preparing for pleasurable activities, and we also reduced the task complexity. And then we improved his abilities by having him learn a set routine over multiple weeks. So it was more habitual, and that meant that he was better able to use the abilities that he had. And basically the outcome was that he felt independent with his wife's assistance, and he was able to complete showers in under 30 minutes without frustration, and with much cheaper bills, which was a relief to both of them. So I'm just going to talk a bit about the evidence, mainly all the research evidence here. I'm just trying to be a little bit on the practical side of things. But given that pharmaceutical interventions are big business, it's no surprise that they have a lot of research used for change behaviours. But that research is also strong that they're causing much more harm than non-pharmacological interventions. And we're starting to see more evidence for non-pharmacological interventions being as effective as medication use. So I was interested to find a study that came out last month that identified that on average, people using non-pharmacological interventions for change behaviours believed they saw positive effects in just about 90% of the time they were using them, which is pretty good. So what's been found to be working for change behaviour? Research suggests there's some intervention features that are important and some that aren't. It doesn't seem to matter if interventions are delivered in person or if they use technology. It doesn't seem to matter if they involve a single strategy or multiple components. So you should choose what really suits you. What does make a difference, however, is that interventions seem to be much more effective when they're tailored to the individual, and I think that really just seems logical. For people living in their homes with families, some of the more successful interventions are the ones that have a dual role that target the needs of the person with dementia and support caregivers as well. Now, for particular interventions, the most frequently studied ones are sensory approaches. Ones that have the most positive outcomes, mostly positive outcomes, are music, which is the most commonly researched, and also technology-assisted interventions. So things like personalised multimedia devices or robots, although there's only early studies in those areas so far. Things like aromatherapies and light exposure interventions have been found to have benefits, but outcomes are much more mixed. And another thing in the sensory interventions area is that we need to be a little bit more careful because they do seem to have more common negative, short-term negative effects than some of the other non-pharmacological interventions that are used. There's also research into cognitive therapies. So reminiscence programs have been found to have positive effects about half the time. But things like simulated presence interventions, like pre-recorded phone calls, have had widely varying results, and some of them have also been quite negative. Exercise-oriented therapies so promise. Interventions such as strengthening or dance programs have mostly positive results, which is pretty good. And time outside has had positive benefits in about half the studies looking into it. Functional behaviour analysis-based interventions, like Alinka was talking about, so exploring the meaning or purpose of individuals' behaviour, have also shown pretty reliable benefits. And finally, interventions that target families are effective in reducing change behaviours. So whether that involves reducing caregivers' workload and stress, or caregivers learning skills to manage change behaviours themselves, or both, they seem to be working. So finally, I'm just going to touch on a few of my suggestions for the use of interventions and future research. When discussing interventions, I often hear things from staff like, oh, I tried that on a couple of people, but it didn't work, so I don't try it anymore. Something that we've found is that many interventions that are used and researched are done so without actually considering if the person with dementia can see, hear, smell, or understand the intervention. It needs to be targeted at the right level. We need to take into account people's capabilities. In addition, there's also been some early research comparing different interventions for different types of change behaviours. So they had limited data, but they found that people with general change behavioural symptoms have better responses to exercise interventions. People with depression have benefited more from massage, and people specifically experiencing agitation, aromatherapy was best. So we need to pick and research interventions considering the behaviours that we're targeting, using the right interventions for the right person, and to address the right behaviours at the right time, and not just randomly trying things. Secondly, we've got a lack of good information about dosage, timing, method of delivery, and duration of interventions researched. We do this routinely for medications, but not for non-pharmacological interventions. And it's important for research to provide information about how to deliver interventions effectively so that when we use them, we actually know how to do it in a way that works. Thirdly, I think this is really important, that every person and every discipline, health discipline, has something to contribute to this space. That includes the person with dementia, their family, their friends. It includes doctors and nurses and allied health of all disciplines. And we need to recognise that. And for this to form part of people's individual positive support, behaviour support plans, but also the way that our future research is conducted as well. At the moment, we've got really isolated ways of doing things with that target individuals and rely on individual professionals rather than actually working on this as a team and a community. And lastly, and this is a bit of a passion point for me because of where I've worked, but I believe that, and what we've seen is that many people with dementia's ability to learn and to change is ignored. We need to avoid causing people with dementia traumatic experiences that create change behaviours, particularly in places like hospitals. And we also need to research interventions that address some of those traumas. People with dementia can learn and unlearn change behaviours, and this is really starting to emerge in clinical work happening in specialist facilities across Australia. We also need to give interventions enough time to work rather than expecting immediate effects. Hopefully I'm within timeframes, but I'd like to thank you for your interest. I'd hand back to Jade, and if anyone is interested to talk more, then that's something that I would love. Thank you, Jade.
Fantastic. Thank you so much, Lorraine. And please do put any questions for Lorraine or Alinka into the Q&A box if you have them. That was a fantastic presentation. Great to hear that overview of the range of options that we have. And again, that message coming through very clearly that we need to be tailoring and really thinking carefully about selecting the best options for a particular person at that point in time. So thank you. Great to hear about the OT role. So next, I would like to introduce Mia Holloway, our next presenter. So Mia is a team leader for Dementia Support Australia, where she has worked for 7 years, also based in South Australia. So Mia has a background in aged care and paediatric community nursing, passionate about enhancing the lives of people impacted by dementia and finding compassionate and innovative solutions across all ages and all settings. So thank you so much, Mia.
Thank you for having me, Jade, and the invitation to speak today. I think from just listening to both or everyone's presentations, I think coming from Dementia Support Australia, we're all about aligning with what Alinka and Lorraine's research is all about. We're very much person-centred and tailoring it to the individual needs when when we think about our service. So, as Jade mentioned, from Dementia Support Australia, I'm one of the team leaders. So I'll just basically give you an overview of what our services do and who we are. And I've also got a case study that I can go through as well, with an opportunity with questions at the end, as Jade will facilitate later. So I just thought I'd provide you with a snapshot. It sort of aligns with what has already been spoken about. So we talk about behaviours and the psychological symptoms of dementia, and you probably heard the term BPSD sort of spoken about in a clinical context in relation to behaviours associated with dementia. So generally, there's like 90% of people that do experience some type of behaviour. That could be something that's quite mild, like anxiety. It could be nighttime difficulty sleeping. It could be that they've got a different kind of walking pattern now. Sometimes it can be quite mild, but it can be quite severe as well for the person and the carers. And the impact can be quite I hate these words, but disruptive. I don't like to talk about disruptive, but I guess in the clinical context, that's how it's described at times. But I think it's quite distressing for the person living with dementia and their carers, supporting that person through that journey, it's really, really an awful disease. So there's also challenges in the BPSD context. So, there's an overprescription of the psychotropic medications. So with DSA, we have got a really strong focus on the non-pharmacological approaches that we can have for that person living with dementia and their carers. So looking at medication charts and where possible, the deprescribing of those antipsychotics and other medications that are not necessary in a collaboration with the geriatricians that we work alongside, and obviously working with the GPs and the family are at the forefront of those decisions as well. So really thinking about that person-centered approach, and are those medications really necessary, or can we do the non-pharma kind of approaches, which should be the first line that's trialed first before looking at medications. So our model of care at Dementia Support Australia, we've got the biopsychosocial approach. So we really want to learn about the person. People talk about behaviour. Behaviour doesn't happen for no reason. We really want to learn about the person. What's their social history? What's their background? What's their, past medical history? What's happening in that moment to contribute and have that change in behaviour? So unfortunately, at times that person may not be able to express that behaviour and verbalize it well. Like we come home from work and, gosh, we've had a rough day and we've got this massive headache. We can I guess have that self-regulation and go, look, I might just have a bit of 5 minutes to myself, have a quick cup of tea and just relax for a minute before I, do the nighttime duties. But unfortunately, that person living with dementia, there may be something that we really need to unpack and work out and observe about that person. It might be pain, it might be loneliness, they may be living alone, forgetting to drink, they may have a delirium on board. And delirium meaning, for those that haven't heard that term before, they may have an infection, there may be pain, it may be something underlying like a cold, it could be any of those sorts of things that may be contributing to the delirium, like sometimes a UTI or constipation, dehydration, especially in the warmer climates in the Northern Territory. You got someone living alone and then they forget to drink. We've got a delirium that's happening for that person. And oh gosh, we've got a change in behavior because we're dehydrated and we're experiencing that change because we don't feel so good. And then we might have some underlying mood disorders, especially with those changes in the brain. We've got sometimes a low mood that might be happening for that person, or historical mood disorders like a bipolar or schizophrenia or anything that happened prior to that diagnosis of dementia. There may also be under and overstimulation. So, if that person isn't stimulated enough or if they're overstimulated from that environment, we really need to look at that as well as a carer approach. So has the carer, got equipped with strategies to help support that person living at home or in the care home? So sometimes, unfortunately in the care home setting, we've got a lot of unskilled staff or fresh out of uni, not really understanding dementia, and been put in that place of trying to support someone that is experiencing a change in that behaviour. So we need to provide the education and support the staff or the carer that's supporting the person at home of how to support them, you know, in the best way possible. So we sort of talk in different tiers of behaviour, and we use the podiatry triangle. So we speak in so no behaviours at all is a tier 1, and then you go right up to a tier 7. So quite often you'll see you know, a person living with level tier of behaviours will be sort of needing something that's not in sort of mainstream care, no longer being able to be supported at home, and sometimes needs to be assessed to see if they're suitable for a specialised dementia care program. Sometimes they're too severe and they need to be like hospitalised for a lot longer and supported quite intensively for that behaviour. Then we've got a tier 5 to 6, which you may have heard before, which is our severe behaviour response teams, which it's not a special team of consultants, but it's a different sort of level of support and response time. So we can be in the care home within 48 hours to support the care home with things like one-to-one support. It might be that consultants out there, it doesn't matter where they're situated in the country, will be out there within 48 hours to support them. Then we've got the next tiers down. So the 3 to 4 is your DBMAS, which is sort of the mild sort of behaviours. It might be anxiety. It might be that they're trying to leave the home. If they're trying to live at home and they want to go see their mum and dad in the afternoons, and that carer is having trouble, sort of those little early behaviours that we can really put some strategies in place to stop that escalation, leading to like a higher tier 5 kind of level. And then we've got the early diagnosed dementias where, you know, like the person's just been diagnosed with dementia and they're like, where to next? How can we support the person to live at home as long as possible? We've also got programs called like the Staying at Home program, which equips the carers with strategies and things to prepare for the future and equip them with the skills needed to support that person. So I thought I'd provide a bit of a case example of a gentleman that we have. It's a de-identified case example, obviously, but this particular referral we received was for a person that was 57. His name was Tom, and diagnosed with a frontotemporal dementia. So he was diagnosed 12 months ago, and now he's experiencing changes with his mood. So he's working full time. He is just experiencing changes in his mood when he gets home. So he's getting quite angry and frustrated with his family. So that's impactful for, you know, his family, for himself, and not understanding why that might be occurring for Tom. So he's working full time in an office-based role. He's still driving to and from work, working full time. He's got a busy life. He's married with 2 children. One's in high school and one's at university. He's got 2 pet dogs, enjoys hiking on the weekend. So a really busy, full life with this diagnosis that they're trying to manage. So we've received the referral quite early in the piece. So his wife contacted us and just said, look, you know, can we talk through what might be happening for Tom? So the consultant went out to the home and met with Tom and his family with his permission, and just talked through what might be happening for him. So what happened was the consultant visited in quite a casual manner. It's a free service, so it didn't cost the family anything. We met with both the children as well, just a round table, casual kind of conversation with what might be happening with Dad, what's everyone observing. And Tom was quite engaging in that conversation, even though it was about him. Sometimes we'll tailor it differently to the person. It might be that they don't want to be talked about, or that we'll talk to them and then talk to the family on the phone. And we've got different ways of how we would sort of align the assessment process to not be too confronting and can be quite casual as needed. So what we identified was that in this particular situation, it was fatigue. And it turns out that Tom, when he got home, had a headache in the afternoon because his brain's just really overstimulated. He's having to drive, he's having to navigate his way in the traffic, and on his way home, he's also having to navigate his day with that brain change that he's experiencing related to his dementia. So then when he got home, he's got the hustle and bustle of the nighttime routines. He's got his family that are like, "How you going, Dad?" And there's just so many conversations happening at once, which is too much. So some suggested strategies, it may sound quite basic, but they were quite effective. They were all non-pharma. So he had a quick lie down and just a bit of a debrief without the noise. They reduced the noise at nighttime, turning TVs off, and just really just having that low stimulus kind of environment just to wind down from his day. They tried a warm drink and a snack, and just that really conducive kind of environment to have. And then he also, as guided by his GP, had some Panadol, and it was quite effective. We also provided some strategies to Tom and the family about, not sort of challenging Tom when he gets in the door about his day and how's it been, and not challenging his mind about like how their day's been, but really slow things down. So the outcome was that he was, he felt quite resilient in the afternoons after having that little break. For his evening, he was less grumpy, as they use the term. And we provided those strategies that, for the family when he does get home, of how to, just really simplify the conversation and just really tone things down. We also lined him up with the Carer Conversations, which is an online support group for those experiencing FTD as well, which they felt a little bit, felt more connected and less isolated from that, joining that group. So on that note, so we've got a couple of different programs which is really helpful. It's all online, so anyone in Australia can join up. It's free and connects those living with FTD. I think it's quite a traumatic kind of type of dementia. Usually got, carers, they're quite young, family, teenagers, excuse me. Navigating how do we support their parents, etc., through this. So you can register online through our website, or you could also give our helpline a call and we can help support you how to do that as well. And then we've also got an online program, It Takes a Village, which is equipping the carer and the person living with dementia and extended family of how to support someone to live at home. And that's not just FTD, but that's any types of dementia, and how to navigate, supporting them through that journey. So that's online and after hours to capture those working carers as well. And that's called It Takes a Village. But I'd really highly suggest, if you're living in Tasmania or Northern Territory, we've currently doing some programs there as well in person, where you go to the retreat and connect with others in person if you can. And then we've also got other providers that support the staying at home program nationally, that we can point you in the direction of their supports as well. So as I said before, we go anywhere in Australia, we charter planes, we go anywhere to support the person. So it doesn't matter if you're living in the middle of Australia, you can see where you go there. So, or if an in-person support isn't sort of the way you'd like to approach things, we can also do things over the phone as well. So that's our website, and we've got an online chat, we've got the helpline, we've got email. So yeah, whatever avenue you would like, I can post these slides, or if you've got any other questions later, please let me know. So thank you for that. Hopefully I didn't go too over time or too time.
Thank you so much, Mia.
Thanks.
That's fantastic. We will absolutely share your slides. That gives a really great overview of what DSA services can look like, and great to have linked to so many follow-on supports programs and services. So thank you.
Thank you.
So to really kind of round off our conversation today, it's now my pleasure to hand over to Rebecca Becky Layton and her husband, Tom. Beck is a dementia advocate and also a member of our YOD-SIG Executive Committee. So Beck has posterior cortical atrophy and is going to share her reflections on the event today. So Beck, I'm really interested to hear whether the conversation has resonated with you, and if you have any kind of final thoughts for us to take away.
I've actually had an epiphany in that I'm a teacher. I was a teacher. I'm no longer a teacher. I wish I was still a teacher, but I'm not. And PBS is, how teachers survive in schools. And so I've kind of had this epiphany that all the things that you're talking about are all the things I already know, and I'm already sort of practicing myself in our family sort of setting, setting goals, those sorts of, well, knowing the person. The first step is knowing the person and trying to figure out what's driving their actions. And that has just been an amazing thing for me today, because that's, you know, it's something that I know. It's something that's in my brain that I will never lose. So it's been really great for me to listen in. Tom and I had earlier this morning, we sort of had so that was just my sort of first reaction to what I've heard today. But earlier we sort of put down a few points that hopefully would be helpful for people there. So hang on. Oh, what would positive behaviour support look like for me? And in reality, hang on. Sorry, just here. I'm trying to read my notes as well as thinking it through. One of the difficulties I have doing these seminars is that I can only hold one thought in my mind for a short period of time. So this might be going all over the place, but we'll see how we go. So some of the notes we took down earlier were things that are important to me in terms of positive behaviour is I have a NDIS package now, which is a very generous one at the moment. That may change, but having consistency in support is very important to me. And I've been fortunate enough to have hit on some very talented. I don't know how I managed to do that, but I don't think there's any kind of rhyme or reason that I've ended up with a really good team, because I know of other people who are still really struggling to find people that they can click with and they understand, and they're, you know, they almost know you better than you do. So they know when to stand back, they know when to come forward, they know when I need to go to have a sleep or a rest or whatever. So it's just that and it's really annoying if they're away because you just don't have that consistency in your care, and it always brings me down if one of my carers, one of my favorite carers can't come in. Then, you know, I'm not going to have a good day. I know that. So often the care time will be cut short because I'm just over it. So that's one of the points.
We talked a lot about, if I jump in, linked with that, I think when we were talking before, what we really notice is with different people providing support, there's a very big difference between providing a direct kind of care and providing skilled support that enables or empowers someone, and keeps them up, was the wording that Beck used, and doesn't sort of cause wallowing in depression, or which can quite easily happen. And so in our experience, that sort of shift is rare. Actually, it's a really rare skill, and there is a tendency for people to provide a very direct support, which is kind of doing for rather than working with.
Yeah.
And that actually
enabling me to say what I want to say or do what I want to do, that sort of stuff.
And it tends to kind of actually cause a perception of Beck being much more disabled than she is.
Yeah.
And can give an image of that, and that's a very common kind of occurrence. So we talked a lot about that, and the wording that you used, Beck, was that when you get that type of support, it's gold. Like it's
and I think that's fantastic. We have actually just gone on to 1 o'clock, but what I would love to do, because I think that is such a powerful message to kind of end on, it is that uplifting support. It is that, again, personalized, tailored wraparound support. And I really hear that importance of consistency. And I wonder, Beck, if you wouldn't mind if we have those notes that you've prepared, that we can circulate that with the recording, with all of the fantastic resources that have been shared today. I might just ask all of our speakers just to put their cameras back on. It has been such an amazing conversation, and I think the fact we could go on for another hour at least, I think shows how important it is. And I think as a YOD-SIG network, we would really like to continue this conversation because I think there are so many aspects that we need to explore further together. But I would just really like to thank you all for being so open and generous in sharing your experiences, your stories, your reflections, and again, hope that we can continue this together into the future. We have got a few questions in the chat that we'll make sure that we've answered, and again that we will circulate in response in follow-up from today's webinar. So again, thank you all so much for being here, and I hope you've got a huge amount out of today's conversation. So thanks everyone. See you.